Andrea Buchanan's illness started when she was gripped with a coughing bout in the middle of a windy street. She wrote that, "When I coughed and coughed the wind out of my throat that day, when I choked on everything that was choking me that day, I also somehow ripped a small tear in my dura mater, the tough membrane covering my brain and spinal cord." Unbeknownst to her at the time, Buchanan said, "At that moment, my cerebrospinal fluid was already beginning to leak out of the tiny, jagged tear somewhere along my thoracic spine." What followed, she said, was 9 months of intractable pain and the inability to be upright for more than minutes at a time. She explained that her headache improves a little when I lie down, but being upright for more than 5 minutes brings the headache to full force. She added, "Having to be upright for more than an hour, even if I'm just sitting, not moving, basically wrecks me." Buchanan had developed spontaneous intracranial hypotension, or SIH, a condition in which the intracranial pressure falls below normal levels spontaneously. She was narrating her illness story in her memoir titled "The Beginning of Everything: The Year I Lost My Mind and Found Myself." Hello, I'm Ibrahim Imam and welcome to this episode of the Neurology Lounge podcast titled "Drained: The Prostration of CSF Leak." Buchanan brilliantly portrayed the pathophysiology or mechanism of SIH when she said that she developed headaches because my brain, no longer cushioned by a healthy waterbed of fluid, sank to the bottom of my skull. Apart from direct trauma, the risk factors for SIH include connective tissue disorders such as Marfan's syndrome, Ehlers-Danlos syndrome, adult polycystic kidney disease, neurofibromatosis type 1, and something called Lehmann syndrome. Low pressure headache may also be iatrogenic or caused by the doctor when CSF leak develops after a spinal tap or lumbar puncture. Another person who wrote of her experience of CSF leak is Karen Paddock in the memoir titled "Karen's Journal of CSF Leak Headache and Chronic Pain." Published posthumously, Paddock described how her illness started after what she said was a minor car accident. She sustained a sideways whiplash injury during which she hit her head on the car door. This marked the onset of her daily chronic neck pain and headaches. She wrote that 1 month after the accident, I began gradually to develop a headache that went completely away within minutes of lying down, and the headache came back within minutes of being up. She explained that the position I lie in does not matter. Back, either side, or face down, my headache goes away within a few minutes and returns within a few minutes of being upright again. This relationship of headache to the upright posture is central to the manifestation of low intracranial pressure. The headache of SIH typically starts within 15 minutes of getting upright and is relieved within 15 to 30 minutes of lying down. Curiously, the headache is occasionally relieved only when lying down on one side. And even more intriguingly, it may be triggered by head shaking. And rarely, it may have no relationship to posture whatsoever. That's the nature of neurological disorders. To add to the complexity of CSF leak, other conditions apart from low CSF pressure can cause postural or orthostatic headaches. These are headaches brought on by standing up. On top of this list are low blood pressure and something called postural orthostatic tachycardia syndrome, or POTS. Apart from headaches, SIH may be accompanied by auditory symptoms such as hearing disturbances and a fullness in the ears. And there may be impaired hearing and tinnitus triggered by standing upright. Other symptoms of SIH are diplopia or double vision, facial numbness, facial pain, and spasm or weakness. There are also some unusual presentations of SIH, such as altered taste perception, Parkinsonism, ataxia or impaired balance, cognitive impairment, altered consciousness, and even coma. SIH may also present with the intriguingly named condition called frontotemporal brain sagging syndrome, or FBSS. This tongue-twisting name accurately captures what happens. The brain literally sags because of the low intracranial pressure. Curiously, FBSS can present as a dementia with apathy, disinhibition, aggressive behavior, and even inappropriate sexual activities. These are symptoms also seen in a condition called frontotemporal dementia. CSF leaks are classified into three. Type 1 is caused by a dural tear, as we have seen so far. Type 2 is caused by diverticular or outpouchings of the dura covering the spinal fluid. And type 3 is caused by a direct fistula between the CSF and a draining vein. Thankfully, Buchanan had straightforward SIH, the type 1 variety, but this is an illness that eluded diagnosis for too long. And this is not unusual because the road to a diagnosis of SIH is often long and tortuous. Buchanan described how she floated through the fog from one specialist to another, enduring skepticism and condescension and strange, barbaric-seeming procedures. And it was only when she was assessed at Duke University that she said, "A team of neuroradiologists immediately recognized my constellation of symptoms and set about fixing me." It even took longer for Paddock to get her diagnosis of SIH. She said she visited about 35 different doctors who either said there was nothing wrong with her or admitted that they just didn't know what was wrong with her. After giving up on doctors, Paddock visited alternative practitioners for the following 24 years, finding only temporary benefit with what she referred to as cryogenic nerve freezes of the occipital nerve. She eventually saw a doctor 22 years after the onset of her symptoms, who said her symptoms were suggestive of a CSF leak and advised her to see the experts on the condition. The investigations of SIH often starts with an MRI scan, which may show subdural hygromas or hematomas. These are fluid or blood collections respectively around the brain and the spinal cord. And when the MRI is carried out with the injection of a contrast or dye, it may show enhancement or brightening up of the meninges, and it may show outpouchings of the meninges called meningeal diverticuli. The brain MRI may also show engorgement or distension of the veins or venous sinuses, as well as of the pituitary and the brainstem. And in severe cases, the MRI may show a sagging brain with possible collapse of the ventricles. And in the spine, the MRI may show what are called spinal longitudinal epidural collections, or SLECs. They may show a syrinx, which is engorgement of the central canal of the spinal cord, or it may show meningeal diverticulae. Another abnormality that the MRI may show in SIH is superficial siderosis. This is deposition of iron on the surface of the brain. At lumbar puncture, the CSF opening pressure is, as expected, low. But the CSF may also show an increase in the number of cells and the amount of protein, and it may show a yellow discoloration called xanthochromia. And it is reported that the flow of the CSF is slow, and there may be a sucking noise when the spinal tap needle is inserted. This is presumably because the low pressure draws air into the spinal space. The diagnostic test for SIH is a computed tomography myelogram, or a CT myelogram, and this often shows CSF leak at the junction of the cervical and thoracic spine, called the cervicothoracic junction. It may also show what is called the hyperdense paraspinal vein sign if the SIH is caused by a CSF venous fistula. However, Buchanan happened to be among the 50% or so of people for whom the leak site is not observed on CT myelogram. In Paddock's case, however, the CT myelogram showed not one, but 7 spinal fluid leaks. Makes you wonder something is making her vulnerable. When a CT myelogram is normal, a digital subtraction myography may show such abnormalities as a CSF spinal fistula. Other imaging techniques for SIH are radionuclide cysternography and transorbital ultrasound, just for the doctors. The conventional treatment for SIH includes bed rest, adequate hydration, oral caffeine, abdominal binders, and adopting the Trendelenburg position, lying on the back with the feet up. Most people with SIH will, however, require an epidural blood patch. This is injection of the patient's own blood into the spinal canal to try and literally patch the leak. Indeed, the first definitive treatment that both Buchanan and Paddock had was a blood patch, and they both got immediate relief following this procedure. But both also developed a sad complication of the blood patch, rebound high pressure headache from rebound intracranial hypertension. Buchanan wrote that little is understood about rebound intracranial hypertension, even by neurologists and other doctors who work with headache patients, other than that it is a new headache that develops after blood patching. Furthermore, she said, the severity of these rebound headaches is not dependent on the volume of blood in the blood patch a patient receives. You can't win that either. The treatment of rebound intracranial hypertension is to lower the pressure with a diuretic. If a blood patch is ineffective, other measures to seal the leak include the use of a percutaneous fibrin sealant or a glue, ligation of the diverticuli, and surgical patching of the tears in the dura. And in some cases, saline or salt solution can be infused into the spinal canal to increase the intracranial pressure. Paddock even had dural reduction surgery, what she described as cutting off the back of several vertebrae and making the dura smaller. In her case, even this procedure failed to break the vicious cycle of low pressure headaches and treatment with blood or glue patches, followed by high pressure headaches and treatment by diuretics, spinal taps, and lumbar catheters and drains. SIH is, to put it mildly, a headache. To explore CSF leak further, I will be speaking to GP Bernadette Hard, who wrote of her experience of CSF leak on the aptly titled CSF Leak website, which is owned by an organization in which she is also a trustee. Thank you very much for listening or watching this podcast. If you found it enlightening, please tick the like button. And better still, why don't you subscribe to the YouTube or Spotify channel so that you don't miss the next episode of the podcast. Whilst waiting for this, why not browse my website called Neuro Checklist, and why not check out my book called Surfing the Brain. Thank you very much for your time.